Good afternoon, everyone. Welcome. Happy New Year on behalf of the Lee Kum Sheung Center. At this point, usually we have either Dr. Laura Kubzansky or myself introducing the speaker. As some of you know, Laura is on sabbatical, so I've had to introduce myself and also give the talk. So I thought I'll keep praising myself, say all the wonderful things about myself and then give the talk, but I won't waste your time. My name is Vish Viswanath. I'm one of the two co-directors at the Lee Kum Sheung Center at the Harvard T.H. Chan School of Public Health. Laura Kubzansky, my esteemed co-director, is on sabbatical in London. She may or may not be able to join, but she is here with us in spirit. We hold these webinars monthly. We send out this invitation. So this is the first of the webinars in the years 2022. So Jamie, as you know, Jamie and Melia send out the information. So hopefully more people will sign up as we go along. So happy New Year. And here we go with this presentation. I will be doing the first presentation, for the first webinar for this year, calendar year. And then more information will be coming for the future webinars. What I want to do today is actually present some preliminary analyses for a study we began in India, actually to be specific in Mumbai, India, on adolescent well-being. So let me, I'll just speak, about the study, give you some preliminary data, and then open it up for questions. You start shortly understand what we are trying to accomplish as a part of the study. Please feel free to put any questions in the chat. Jamie and Chuno is monitoring the questions. And at the end of the presentation, I'll be happy to answer any questions. If I don't have the answers, I'll make them up. Or, you can't joke on Zoom, so nobody reacts, So seriously, I will try my best to answer. If not, we'll find the answers for you. This is a project, focusing on, particularly as a communication scientist. I'm a translational communication scientist, which means my interest actually is in how does evidence base that is generated in knowledge or research settings is translated to influence policy and practice. That's my goal. We generate a ton of knowledge, but how does it really get translated, if at all, is what we want to focus on. And within that, my group focuses around issues of inequalities. Does everybody benefit from the translation, or who benefits? And what is the role of communication, because of the focus on translational communications. And there's a huge team that has actually worked on it. I have mentioned a few of them. They are all on the call. Dhruti and Dhawan, Meswin Bekalu, Rachel McLeod, Ramya Pinamaneni, Dan Gunderson, and myself. And then we are working in partnership with an organization in India, and we are extremely grateful to them. Actually, they deserve a lot of credit, and you will actually see a lot of acknowledgement of their efforts in this study. So the goal is sort of, especially for this broader rationale for the study, let me put it that way, are twofold. So one is really focusing the translational approach to studying well-being. By well-being, we are really taking on the WHO's definition health is not just an absence of disease, but a complete, state of physical, mental, and emotional and social well-being. With that in mind, we wanted to see, to what extent, work is being done in the field based on evidence, and to really develop a foundation of knowledge on the role of communication in positive health among adolescents in India. The title says youth. Youth is where we want to go ambitious. We are very ambitious in terms of developing a long-term cohort and following the adolescents for the next 10 years into their young adulthood. But I will come back to that, how we have to moderate and become much more modest because of COVID-19, but I'll get to that in a second here. But there is very little information on the positive health in terms of research or evidence-based. There's a lot of work that is going on about stress and suicides and mental health now in India. On the other hand, if you know, many of you know about India, actually there's a lot of practice around mental health and positive health in India, but that doesn't always inform research. So that basically those are the two goals, are two broad reasons why we are doing this study. So let me just spend a couple of minutes on what I mean by, translational communication. Sorry, in generally, this is a question I often ask. Those of us who are studying translation, knowledge translation and implementation, diffusion, dissemination and implementation, ask this question: how long does it take evidence to move from research settings to changing policies and practice? And what you see is, there's one study that came out, one paper that is one of the most heavily cited papers by Ballas and Boran in 2000, who found that it takes 17 years for research to reach practice and change practice. And only 14% of the research actually reaches a patient. This was done in a clinical setting. This was a review. And only 18% of the administrators and practitioners report using evidence-based in their practice. So you can see, if you buy these data on their face, it's a very depressing figure. So here we are doing so much research, but it taking 17 years. In the world of organizations or companies, no company can survive if it does that. But that's what happens in this world. And interestingly, a new paper has come out by David Chambers and colleagues, which is an update of this finding just about a couple of years ago. And they basically found the same thing. It is still taking 17 years in most cases, maybe a little less in some cases, but the translation is still taking a lot of time. So for those of us, on the other hand, those of us who are students of communications realize that, is there a possibility of this accelerating? And especially with the information and communication technologies, is there a different way to think about this knowledge translation? So some of the challenges I think we see because of this translation is that most of the interventions we do in this research settings are good for testing our assumptions and theories, and that's very important. I think it's very critical to do that. But the problem I think is when we try to scale it up, the dose or the strength of the stimulus, I guess if you're in the experimental world or in the intervention world, what we call the intervention dose is not sufficient, to really make that big a difference. I think we can tinker with it and come up with sufficient dose, but again, when you take it into the real world conditions, it's very difficult to replicate those conditions, from the experimental or the intervention conditions to the experimental world, On the other hand, what we are increasingly seeing is there's a great demand from policymakers and practitioners asking for evidence-based, particularly in its translation in an easy-to-use form, so that they can actually implement it. One example I have is in the world of tobacco control. If you look at what we have done over the last 60 years, in fact, I was talking to a colleague of mine this morning who runs one of the largest tobacco control organizations in the United States, doing amazing work, and she was telling me that, how, tobacco use has really fallen in the US, except, there are pockets where there's still consumption, and how her organization is focusing on vaping, right? So there you can see a clear example of a great marriage between evidence generation in research settings and, influencing policies and practices and a reciprocal process between them. And that's a great example and a model, but in the area of positive health, that has not happened yet. So there is a lot of good work, in the field that is taking place. There is some evidence around mindfulness, meditation, that is happening in the practice world that was subsequently tested in more research settings and to find the efficacy. But there is that kind of a platform or a bridge is absolutely important. And second, I think Larry Taylor talked about it. I'm sorry, Larry Green, a very famous public health practitioner, about practice-based evidence. Really, can we learn? Because I think practitioners do things and they do it at scale. It's quite incredible, what they do. And the question is there a way to evaluate it and learn from the practice world, and then see if there is a way to implement it in some ways, So, so my point is, so we are trying to figure out, if there is a way to look at the practice world and translate and generate evidence base of what is working and not working. Let me also talk briefly about the context for this study. There is a tremendous change happening in India. I think that should not be a surprise. I use the term phrase characterological transformation. It is not my phrase. It was used by a very famous sociologist, Daniel Lerner, political sociologist, talking in 1950s about modernization. I think, and that kind of development, is not just material development that is taking place in the country. If you look at whether it is longevity or whether it is improvement in health conditions globally and also in India, but there is also great churning in the society, and that is also complemented by the information and communications technologies revolution in India. So, for example, the last time I looked at it, and my numbers are, I think, outdated by this time. India has a population of 1.3 billion people. The last time I looked at it, I think India had something like 900 million cell phone subscriptions, right? So, it's trivial, right? And so trying to understand that context, that development. The other is stressors associated with structural conditions. While the country has gone wealthier, it has improved on a variety of characteristics. There is also deep disparities and tremendous stresses associated with this kind of a social change. So there are people who are virtually working as a back office for the entire world, managing the computers, etc., and writing code. And at the same time, there are increasingly, a number of conditions that continue to foster inequalities. Particularly on the adolescent side, there are tremendous stressors. One example I can give you is there is so much competition, for example, to get into a good school. or a good college, everybody's all the time studying there, preparing for these exams. In fact, I often joke that I could never make it in India if I were to go back now. It is so intensely competitive. And there is a tremendous stress associated with it. There's virtually no adolescents in India anymore because they're all preparing for these exams. And we have very limited knowledge on what is the impact on adolescents. As I said, there is a lot of attention now being paid on adolescent mental health, but very little knowledge on the positive health of adolescents. So I think this is this provides a good context for us to do this study. So what our goal in this project was to conduct a longitudinal study involving school children in Mumbai, actually focus on adolescents, and to measure, key variables, including, personal and social assets, resilience, life skills, and of course, health behavior. And we wanted to determine the key characteristics such as health communication behaviors and availability of assets and resilience associated with health, and to determine if these associations change over time. And what we were working with this partner, so we wanted to see what impact their interventions have on adolescent and the students who participate in their interventions in the schools compared to control schools. And particularly we wanted to track if the interventions have an impact over time, not just in a one point, not just at one point in time or a 1 year intervention. So so we partnered with this organization called Salam Bombay Foundation. Some of you may be familiar with it, but it's an amazing organization in Mumbai, which was started as a tobacco control organization. Padmini Somani, one of the founders, the founder for the organization, was personally interested in addressing tobacco control issues. And so she started it in 2002, focusing on what are considered as at-risk children growing up in Mumbai slums. Some of you know this, the tobacco use is very heavy, particularly chewing tobacco. And there are no taboos. The norm is to use tobacco, and the norm is to get children to go out and buy tobacco. So it's very widely accepted, and children go out, and there is good documentation that children also continue to indulge in it. The program started with that, but over time it has expanded considerably to providing life skills for the students, not just tobacco or physical health, but actually life skills, promoting engagement of students in leadership, promoting the advocacy initiatives, and providing mentorship to them, and making them participate in programs, etc. So the goal is to build self-esteem, improve connectedness between the students, the children, and their schools and the communities in which they live. And the foundation itself has two programs. One is what they call a super army. So what they do is they adopt certain schools, and once they get the permission from the principals of the schools, they go ahead and introduce the program in 7th grade and continue it through the 10th grade. That is the end of the school there, and after that they go to what is called as a junior college. And so they all the students who are willing to participate are enrolled in this program called Super Army. It's basically a low-dose intervention that delivers health-related education, refusal skills, mentoring, and opportunities for engagement, community engagement, and advocacy. And then a selected group of students who are interested are given participate in additional programs in different, what they call as academies. So some students participate in sports academies, some participate in media academies, vocational skills or art skills, and the interesting part, the reason I got interested, in getting to know the program, the foundation, is it is just not about a specific program, but that relationship they build with the organizations, with the mentors, that really matters a lot. And that's what I was telling them is you may or may not have an impact on specific micro skills you're interested in, but it is this larger skills of mentorship and championing and participation and engagement, which might have a very positive impact beyond what you're trying to do. And that's what we wanted to focus on. So it was a good marriage in some ways between the academy, where we are interested in the evaluation of this intervention, and providing the evidence base for the foundation for what they are doing. So this is just a indication of how different programs work, including, as I said, a lot of the students participate. It's in variety of these programs. I have had an opportunity to meet them. Whenever I go to India, I have a chance to. It's just such a enriching, wonderful experience to talk to these students and watch them bloom, as a part of this program. And what we have done, this is a very busy figure, but I just wanted to highlight that unlike studies we do typically in academy, with our set of hypotheses, what we did is we actually worked with the organization itself, trying to figure out what is it they're trying to achieve. And so it's very participatory in that sense. So we developed this so-called theory of change that you're seeing. Really identifying both the contextual conditions under which this is taking place, this education or intervention, but also what are the inputs and intermediate and the long-term outcomes that the organization is aiming to achieve. This was an interesting participatory exercise, where our team is sitting with their team, trying to identify step by step what they are trying to achieve over time. Not that they will go through all of these or they will achieve all of these, but it's a nice way to document this and make any mid-course corrections in their own interventions if needed. So what did we do? So what the program, as I said, is introduced in schools. These programs are, in what I think some of you are from India, so you may know this. These are all public schools in the American version, or what we call as government schools in India. Government schools are under-resourced, tremendously under-resourced in India. There may be some schools, there are schools with just 1 or 2 or 3 rooms in rural areas, even in urban areas. The physical infrastructure is very limited. Most of the people with resources generally do not go to the public schools or the government schools, but these are very critical institutions, providing access to education, particularly for students from lower socioeconomic conditions. So we, as I'm sure some of you have been there. I've been there many times. It's just a very different environment. So the principals, with the help of the partners, we briefed the principals and teachers about the study aims and procedures. And once we got their permission, we actually, the staff member for the Salam Bombay Foundation went to the school and talked to the students, briefed them about the study, and requested a parental consent. So the students took a letter and a form. The letter had to go through many drafts. Won't be surprised, so that it is easily understandable. And then and the students were expected to bring back the parental consent. So on the day of the survey, if we got the form, and then we discussed the confidentiality issues. So students who brought back the form were taken to a different room, all 7th graders, That's when we first year of intervention. So that's when we administered it. So they were taken to a room and they were administered this questionnaire. The rest of them who did not bring the permission were given another activity. And the reason I'm going through this in detail is also because you can just imagine the logistical challenge in implementing something like this in a school setting of that kind with this. And so they were administered a 30 to 40 minute survey. We used a Kobo platform through tablets. And of course, most students are comfortable with it. With some kind of a tablet, they're used to swiping, etc., easily from left to right, but we also trained them. And then they, after getting the training, we administered the survey in 2 languages, local languages, Hindi and Marathi. And so so these are the measures I'm going to talk about today. We have a number of measures, but just I wanted to provide you only with some preliminary data today. So one is of interest to us. We were interested in measuring class, or technically social stratification. And obviously it is of interest to us, communications, it's of mind for our lab, demographics. And then we had 2 kinds of broad health measures. One is physical health, other is positive health, particularly around, happiness, subjective well-being, and resilience. So there were about 55 questions with different scales. We tried to collect scales that were used in the literature. One of the challenges was, are they conceptually equivalent when you translate them to apply them in the context of India, also translate them into local languages. That is an issue by itself. And that's one of the reasons we did this study, to understand that equivalency issues. So these are some example, of the measure questions we had. For example, class was measured in 2, socioeconomic position was measured in 2 ways. One way is we were looking at assets they have. So, for example, how many rooms do you have in your house? Do they have a separate room for a kitchen? How is the home paid for? The source of drinking water? What kind of a toilet do they use? Some of them have public toilets they have to go use. And whether they have certain things within the household, whether it's electricity or radio or television. These settings that you see in the photograph are not are very typical. Any of you, anyone who has been to some of these slums, should be familiar with this kind of setting. I've been there many times. It's not at all unusual for 4 or 5 people to live in one room tenements. We also had additional questions whether any member in the household has a mobile phone or a smartphone, and a few other things like a watch or a car or a truck, etc., and whether the students themselves have any of this. So these are some of the examples of the questions we had on assets. We thought of measuring income. We have a other standard indicators we use, such as occupation, parental occupation, etc. We found that income is extremely difficult to measure. It's notoriously difficult for confidentiality reasons, number 1. Number 2, the students may or may not be aware of their parental income. So this is the one we felt that a 12 to 14-year-old can answer reasonably without difficulty. So those are the assets questions. And then we also, let's see. Measured parental schooling. This is a very standard measure that is widely used, particularly in low and middle income countries. Both father's education and mother's education, as well as employment. didn't use employment in the analyses today. I'm going to report on, but we did. I will show you the data on father and mother's highest grade completed. And then we also have a variety of media use measures. Today, I think I'm going to report only on one of them. This is on standard media use measures where we were asking them questions about how many times they watch television, listen to radio, play games on computer or mobile phone, watching videos on the internet, watching movies in the theater as opposed to videos on YouTube, or using internet for any purpose if they have access to it, and social media. We actually had more detailed questions on social media because we are very much interested in that from a well-being perspective. I'm not going to report on all of that today, but we will report on this measure. For some reason, it's not moving very quickly. That's why you see this awkward silence between slides. Okay, and then physical health. So health was well-being, or health was measured in two ways. Physical health, so we asked them about nutrition, fruit and vegetable consumption, physical activity, exercise, and self-rated health. We also asked them a number of questions about supari. Supari is betel nut. Some consider the two reasons why we measured consumption of betel nut. Betel nut is very common. There's no taboo against consumption of betel nut. And betel nut itself is sort of mildly carcinogenic. And sometimes it's consumed with tobacco, with betel leaves. The other is some consider it as a gateway product for tobacco consumption subsequently. So we measured that. We also measured tobacco use and a few other health measures. On the positive side, we measured subjective happiness, an internal resilience scale, Connor-Davidson's. This is the so-called bounce back version of the scale, and also how they bounce back from adverse conditions and how they are able to adapt and cope with life-changing, with changing circumstances. We also have another resilience measure, child and youth and community resilience measure, which I'm not going to report on today, which focuses much more on their connection to the family, community, and schools, etc. And then we also measured self-esteem. So what I want to do is just show some preliminary findings, maybe take next 4 or 5 minutes, and then stop there to see any questions or thoughts you have. So we will report on each of these: physical health, positive health for today, and then we also were interested in just looking at the association between physical and positive health. I'm going to use the term association throughout because this is sort of a wave one study over time. If we go back and collect subsequent waves from this cohort, we should be able to report with greater confidence a causality, but not now. So we looked at demographic characteristics and physical health and positive health, class, asset index, communications, etc. So here are some preliminary findings. Physical health, obviously nutrition was not related to age, but we found an interesting pattern association between gender and nutrition. Girls reported better consumption of fruits and vegetables. Boys reported more exercise. Compared to girls. Girls are the reference group here. There are several hypotheses. One can, propose why that is the case. We can come back and talk about it. But if you're familiar with India, some of you are, the roles are gendered. Girls at that age are started, there are expectations that they will start helping, in the household chores or taking care of the younger ones. That could be one reason maybe that they're less likely to engage in physical activity outside home. There are many other reasons for that. And then okay. And then, of course, we also, from physical and social class, what was interesting about the role of social class is that obviously higher assets are scoring higher on asset index is related to better self-rated health. For many of you know, self-rated health is a very robust measure, widely used in our field. And certainly, not surprisingly, social determinants matter here, particularly in terms of socioeconomic position. Father's education also was positively associated with self-rated health. And of course, father's education is also related to nutrition. Surprisingly, mother's education was not related to physical health. This is a surprise because in other studies, mother's education is actually matters quite a bit. We may have some reasons for that. We can come back and talk about that. And then communication, most of the communication measures did not matter when it came to physical health. Mass media exposure, the patterns, it's not very clear. There is some moderate exposure to TV and internet video associated with better self-rated health. This is in contrast to, here where television is usually related negatively to physical health. However, watching movies in a theater is associated with poor self-rated health. As you can see here, this is an interesting finding. We'll come back to the role of watching movies in theater. I'll come back at the end of it to have proposed a couple of hypotheses on that. Now, on positive health, there are no associations in terms of demographics. Okay. So now on positive health and social class, so in general, it's very clear, again, scoring higher on asset index, is associated with subjective well-being, and happiness in this case is a measure we have. Particularly if you are, compared to people who scored the lowest on assets, people who scored higher, on levels 2, 3, and 4 seem to be happier, so at least greater association, though not at level 5. It could be, and again, father's education appears to be related to happiness, but mother's education doesn't seem to be associated here. And then media, again, did not have a significant association, except, again, watching movies in a theater is negatively associated with resilience and happiness. That seems to be standing out. There is some, pattern of media exposure, positive association with TV and internet use, but I'm not very confident in making any predictions or assertions at this point. But certainly, again, movies stand out, for their negative relationship with subjective happiness and the resilience and self-esteem. So, again, association, the last one I want to spend a minute on is this. Just we were curious about the association itself between physical health and positive health. Obviously, physical health and exercise are positively associated with happiness. Again, self-rated health and exercise and nutrition are all positively associated with resilience. And of course, self-rated health and nutrition are positively associated with self-esteem. It's not a surprise, but it's nice to know physical health and positive health are related. So what do we conclude from this at this point? These conclusions are, number one, these analyses are preliminary. We are still trying to do the analyses and work on them. But tentatively, I think class matters. It's very clear. Having material assets appear to matter for both physical and positive health. Father's education appears to be significant in both cases. Mother's education is not. As I said, this is a different finding from other studies. We can only speculate because we haven't measured this. That's why we are using this as a launching board for a more systematic, for a second wave where we are planning to ask more questions. But it is possible, that decision-making it doesn't lie with mothers in these households. It's a question of autonomy over who makes these decisions. We have a large study in India ongoing for adults, particularly for pregnant women and new mothers, around decision-making and autonomy around feeding-related practices. And we are learning, as autonomy matters, and who makes a decision in the household matters on a variety of these issues. Communication at this point, there are no discernible patterns, though internet and TV viewing seem to have some positive impact. And we also saw that in other studies, even among adults. And there is a negative impact of movies, which is much more clearer. This is interesting. We don't have good hypotheses at this point. I can say that in a couple of papers we published for for adults on tobacco use, we know that movies are strongly positively associated with tobacco use. And part of the explanation there was clear that the content matters. Tobacco use was very common in India in movies, that portrayal. And we know that depiction or portrayal of tobacco use in movies is very strongly associated with tobacco consumption. So there's something about movies, watching movies in theater, that seems to have this impact. Unless we collect more data on the content, it's very difficult to say anything at this point, I think. So what we are doing is we are using these preliminary analyses, and we will be doing more analysis and use this data to collect, the next round, to do the next round of data collection. So we started using the language that this would be wave 1 of our study, and we would follow up with wave 2, 3, and 4, hopefully for the next 10 years. But unfortunately, because of COVID-19, there was a tremendous disruption. In fact, we were hoping that we would have gone back late last year in 2020, but our partners found out that almost 40% of the sample has disappeared. We are not able to connect with the students. Is it because of dropout? Is it because some of these families are migrant families? As some of you know, because of the recent COVID-19, a lot of migrant families, because of the lockdowns, left Mumbai to go back to their hometowns and native places. Is it because we lost them there? We don't know. So we are trying to figure out, and again, so we were, as we were planning to go back in the schools because of these, surges, the schools were closed. So we are in discussions with our partners in two ways. One, to what extent can we go back and figure out how to connect with these students, replenishing the sample, and ask a very different additional set of questions now, especially around mental health, given what happened during COVID-19. It becomes all the more important. And of course, we also want to make sure that this evidence is used by Salam Bombay Foundation, for their own programming, So I will stop here, and we still have just about 4 or 5 minutes to answer any questions. Thank you so much.
Vish, there's one question for you from Dr. Lerner. Is the 17-year gap specific to public health information, or does it generalize to other aspects of health? And that was from your introduction that you provided.
Right. Thanks, Jen. Great question. What it is they were actually, Bur and Balas were looking at clinical recommendations. That was their focus. So if you have if you are developing guidelines, say breast cancer screening, how long does it take from identifying needs for screening, age, etc., and then translating it to clinical practice. So it's just not public health. It is actually around clinical guidelines and recommendations. And then the updated work paper by Chambers also looked at, actually, they were specifically focusing on cancer screening guidelines and found the same thing.
Thanks, Vish. We have another question from Dr. Allen. He said, fascinating research, thanks for presenting. Do you see any evidence here that might help health authorities target their health promotion material? If so, how might the research findings be brought to the attention of agencies beyond the foundation?
Paul, first, welcome. Thanks for joining us. It's a great question. One of the things is, as academics, we are terrible, at working with governments or translating our findings. There are exceptions. Jen Lerner, Dr. Jennifer Lerner, of course, is an exception in some ways. Who's very good at that kind of a translation. So, but specific to your question, I think, so what we are thinking, what we can do is to generate policy briefs, knowledge briefs that we will share with the foundation, Salam Bombay Foundation. The foundation itself is very good at working with the authorities, especially with the Mumbai government, and now they have expanded to some other states. They actually go and brief the governments very regularly, the state level governments, not at the federal level, brief them, work with them. And so our hope is that we will be working through the foundation to broaden the reach of these findings to influence any practice.
And we have another question here. I'm curious about, when was the questionnaire survey administered to the 7th grade students? Was it right after the conclusion of the intervention or after a gap?
Actually, it is the first year of the intervention. So the intervention has not actually taken place. Intervention starts in 7th grade. They just begin to sort of introduce themselves and the ideas, and the actual intervention, the heavy intervention, takes place 8th, 9th, and 10th grades. So just as they were beginning to enter the schools, they're already in the schools for 8th, 9th, and 10th. But the administration of the questionnaire was on the 7th grade before they began the intervention. So, and our hope was that we will follow this group of kids or children as they move to 8th, 9th, 10th, and then hopefully after that, So.
And we have another question. Can you please share a little more on the impact of gender on health and positive well-being findings, given that gender roles are a reality within a patriarchal ecosystem?
Yeah, that is what we are thinking right now. I think that's a very reasonable hypothesis. I think, the generalizability, let me step back. Right, I think it's what we are finding, especially if you're familiar with the National Family Health Survey, which is on adults, most of whom are women. It's very clear those gendered roles matter quite a bit, right? Because we are seeing that in the physical health, with anemia as one of the conditions and other breastfeeding practices. And the issue of autonomy and who makes decisions on what is fed or what do you eat or not eat when you're pregnant and what do you feed a child is really heavily related to those roles. We also found out in another study we did in Argentina on HPV that actually the, one simple thing like cell phones are actually not controlled by the women in a household, but actually by the men. In fact, the women told us don't send any messages on phone about HPV or testing, etc. And so I think it's a very reasonable proposition that it is a part of that, but we need to investigate and understand that better. We didn't have any questions around the specific roles. I think that's what we want to do and add more questions. Maybe Jamie, if people want to leave, I think we take one more question.
Okay, there's one more question here. I was wondering how you conceptualize the differences and similarities of mental health you mentioned for the next wave versus positive health in the first wave.
So I can tell you on one issue, I think, we did not have very sophisticated. So let me put it this way. This is not an easy survey to field in that context. If you worked in some of these conditions, you will realize how difficult it is to really field this kind of a questionnaire that can be done within the school setting in a class period, I think. If I were to change in wave 2, I would add a lot more questions on mental health right now, and certainly on resilience. We have 2 measures on resilience. We are doing the analysis to figure out how they work, and certainly more on assets. We did a recent study that was led by Dr. Dhruti Dhawan and Dr. Ramya Pinamaneni in the lab, where the same foundation actually made what they call as happy mind calls to these kids who were at home stuck with COVID-19. And even one call made a big difference among these students. Just one call, just to call them up and say, how are you doing? So we will try to find out a little bit more about those kinds of assets that they have to help them survive through this crisis. So we'll just have, we are discuss, all those things are being discussed now, so, without increasing the length of the survey. So. All right, we should stop now, but let me thank everybody. I really appreciate your presence and for making the time. Please feel free to send me questions, or Jamie or Melia, they'll be happy to direct your questions to me. As always, Melia is wonderful. She has posted the next webinar will be on February 23rd. The speaker will be Christian Nishimi. Christian graduated from here and has some interesting work that she can report on. So thank you so much. Everybody have a great rest of the day. Bye. Thank you, Jamie. Thank you, Melia. So.